My topic today concerns, like Henry said, the peri-implant tissue design. I developed, it's not really a new concept, but I'm using it since quite a few years, a concept which is predictable, easy, and reproducible for the aesthetic zone. Because we saw today how Istvan can change people's lives to better. If we are not careful, with home run cases, as we call them, we can change their lives to worse. And the patients with huge defects, usually and unfortunately, are not accidents, but are bad dentistry. So I know that we like to share extreme cases on podiums, but actually, for me, the most important things in life are simple things, and how to deal and restore, in a way, simple cases with great success. So I won't share all these cases with you, I'll share a few. We will focus on single implant restorations. We will go through the surgical procedure and then finish with the restorative part. On the left side of the screen, you can see some sketches, and on the right side, we will see clinical pictures and some videos in order to really comprehend and understand my concept. So this central incisor is hopeless. I'm sure Francesco will agree with me. My dad is also an endodontist, so no chance for me to extract teeth which are not to be extracted. This tooth has to be extracted. It has a fracture on the middle aspect of the root. This is how we proceed. We remove the restoration, and before removing the root, we use the 15C blade, as you will see here, to go up to the mucogingival junction, create a tunnel, as we would like to do in order to place a connective tissue graft. The reason we do that before extracting the root is because it helps us guide our blade or our tunneling instruments, as we see here. It's not a real split thickness flap as we heard from Uli Grunder yesterday, but we mobilize a little bit the tissues. After doing that, we will utilize fine instruments in order to mobilize the two pieces of the root, and we see the defect we have on the mesial aspect. So after doing that, this is a small video, we will proceed with our implant placement. We like to use a round burr in order to mark the proper position and entry of our pilot drill, as you see on the left side of the screen and here, and then we will utilize osteotomes. This is a hammer osteotome here, and on the left side you can see a screw osteotome. Now, the reason I like to use osteotomes, it's not because, like we know from the past, we like to increase the primary stability. This is one thing, but with today's implant design, this is not really necessary. We have excellent primary stability with the new implant designs. The reason I'm using this big and long device, which is 10, 15 centimeter long and straight, is because it's easier for me to see the direction of my implant. So, in my opinion and in my experience, 90% of the failures in the aesthetic zone, it's not because we didn't do any complicated periodontal procedure, it's just because the implant is in the wrong position. So the only time I'm stressed is with my pilot drill. I need to be exact, and then I have a huge device which will point out if my direction is wrong. No water, a very slow device, which really makes me feel safe. So, as you see here on the right side, we stop, we check the depth, the inclination, the direction of the implant, as we heard over the last lectures, is so important. This is my in-cone implant with an aggressive apical part, which I need in order to stabilize. And again, I will use hand instruments. This is my left index protecting the direction I'm placing my implant. I like hand instruments. And this is the final position of the implant. We will stop, check the depth, the inclination, everything. And after we do so, we will place, although there is the presence, the buccal plate is present, we will place a slow resorbable membrane in this area, as you see here. Now, there are two reasons we do so and place this membrane in the alveola, although the buccal plate is present. Number one reason, we all know it today, this is the critical coronal part of the buccal plate is tooth dependent. We know today that the bundle bone will resorb. One way to solve these cases is make a flap and overcorrect the region. The other way, in order to compensate this loss of the bundle bone, is to place a membrane, as you see here, and graft the area with slow resorbable material, like bovine bone. Now, not only we preserve not the bone, but we preserve with this slow resorbable membrane, we have a barrier in order to keep a tent for our soft tissue, but we go also a bit supracrestal and graft even a bit further coronally. And we will see this is very important to do. So after we do so, our assistant will hold the membrane in place and we will graft with a slow resorbable material, as you see here. After doing so, we will place two positioning mattress sutures, a little bit more centered and more apical, 1 to 2 millimeters to our margin. We would like to seal the area here. We do not suture conventionally over the margin and the papillas, because if we suture conventionally, we tend to push everything in and up. So we will suture this way. As you see in the sketch here, we go deep in the palate in order to have two very stable sutures and enter almost at the same position buccally. Now, we heard yesterday that our surgery has nothing to do actually in this scenario with a single tooth implant surgery with the papillas. We know that this papilla belong to the lateral and these, the mesial papilla, belong to the central incisor. We expect some shrinkage to the distal papilla when we're dealing with a central incisor site, because we leave a smaller surface, attachment surface, to this papilla, meaning we only have the lateral holding this papilla and not the central anymore. This is why, in terms of papillas, the most predictable site in the aesthetic zone are laterals. Because if we extract a lateral, we have the canine holding the distal papilla, a big surface, and the central incisor holding the mesial papilla. So what we worry about, actually, after performing this type of surgery, is the mid-facial margin. This is our worry, and this is where we need to have success in these surgeries. So what do we know about this area? We know that epithelial cells, I won't tire you with this, will migrate, and we will have an so-called attachment. It's not actually an attachment, it's very weak. This can already occur 2 to 3 days after surgery. So what we expect to see is this. Most of the people, not all the people, we saw that yesterday in Grunder's lecture, but most of the people, they urge us to support immediately this portion of soft tissue. Well, this works when we're dealing with thick tissue biotypes. This also works when we're dealing with thinner tissue biotypes, but we also graft soft tissue. It will never work, and we will see a case later on, when we're dealing with thin tissue and we do not like to graft soft tissue, for several reasons. One of the reasons I do not, and I minimized soft tissue surgery after I went back in Greece, is smoking. Everybody's smoking in Greece. So periodontal surgery in smokers is not really predictable, and we would like to be predictable. Another study by a good friend, it's a review actually, not a study, by Rompen, is he showed that plastic and acrylic is not a biocompatible material. So it will not really enhance this adherence of epithelial cells. Some people now, and there is also 1 or 2 articles which they say that very highly polished composite we can have an adherence. In my experience, because we would like to have, especially our first provisional restoration for a long period, 3 to 6 months, is not stable, because these acrylic materials are porous material and we might end up with trouble. So what we do in order to overcome this problem is, and not to have a recession, because if you're dealing with thin tissue, the tissue will migrate in order to adhere to a biocompatible surface, is to remove this portion of your first provisional restoration. So it looks like this. We leave a gap, we stay supragingival, and we allow the soft tissue to adhere in a biocompatible surface, titanium or zirconia, and win actually soft tissue, not really surgically. This is the clinical situation. The ugly first provisional restoration with a gap in the margin, and this is how it always heals. Not 1 time, not 2 times, always it heals like this. From this picture, you realize that we do not only win soft tissue vertically, but also horizontally. And it's very simple. Why? We extract a tooth with a margin which was here, place an implant more palatally, we mobilized the tissue, and we gave the soft tissue space to grow in. We know from orthodontics that when we have procline teeth and we bring them back to the palate, we might end up, or we will always end up, with soft tissue coming more coronally, and sometimes even with a gummy smile, which is not even nice. It's exactly the same principle, because we give to the soft tissue the mobility and space to grow in. So after this, we have more tissue. We will utilize than we need. We will utilize a second provisional restoration. We call it transitional, because in terms of 90% is similar to the final restoration in terms of shape. You see here, even with the second provisional restoration and even with the final restoration, we will stay a bit more flat in this aspect in order not to thin out the soft tissue. And honestly, these differences are only visible with our macro lenses. So this is how we proceed, and after maturing, this is the second provisional restoration, as I've told you. We need to pay attention also to the zenith of the margin. Many times with central incisors, it's more to the distal and not in the center. If we go and do the zenith in the center, we will not have a balanced gingival display. Small details, but they make a big difference in patients with high smile line. This is the radiograph, and all the technician needs to do actually is copy our provisional restoration. This is this video you can actually see. It's the first video I posted in Dental XP. You can appreciate also the profile we have also from this aspect. So you can go online and see the video. And without doing anything complicated, you see that in a not very complicated case, we have success. This is the post-op 6 years after, and this is the radiograph, the CT scan 4 years after, and this is what we would like to see: stable, reproducible results. Now, this is the concept. I will not go through it, but we will have it online, these sketches. This is something I would like to focus on. We always say palatal implant placement. It's actually the upper part of the implant, 1/3, which needs to be palatal. The inclination we can change, okay? So sometimes we place it palatal, but with the wrong inclination. So let's see another similar case with a central incisor. This central incisor is failing, as you will see here in the radiograph. Thin tissue we need to deal with, and a beautiful gingival balanced display. The margins are leveled. Now, we extract the tooth atraumatically. Sometimes it takes longer than to place the implant, or most of the times it takes longer. This is the fractured root. And please notice with me where the margin already is, because this is reality and not like many times we see in articles and on podiums. When we're dealing with thinner tissues, already the margin moved apically, and we're losing the game. So if we go and support this margin in order to keep the tonus in the area, we push it further apically. So we either soft tissue graft or we do the marginal migration restorative concept. So exactly the same procedure, membrane graft, and we leave a gap. Please try to visualize this three-dimensionally. This implant is further back to the palate, so this is quite a big gap. And this is how it heals. So we win tissue again without doing anything complicated. This is the radiograph. And after that, we will utilize a final abutment and the second provisional restoration in order to architecture and sculpture our soft tissue, as you see here. After removing the second provisional restoration, you can appreciate these are the clinical evidence we have that these materials are biocompatible. You see the creeping we have of the soft tissue because it was mechanically retained, and a very beautiful and solid outcome also from this view and the occlusal view. We will not go to the prosthetics of this case. We do not have the time. This is a very nice chapter we wrote with two of my friends, Eric Rompen and Eric Van Duren, about the peri-implant tissues in a book from Jack is there, my dear friend. So if you want to go to further details, you will find a lot of information there. Let's see our next case, again a demanding case, a case that we have, or I have, daily in my office. A patient coming, high smile line, not an accident, not a shotgun, just a failing central incisor. This is how we start with our patient planning. We draw lines. We see she has 2 canines instead of 2 laterals. The margins are leveled. We have a small chipping in the central incisor. And this is the defect we have on the distal aspect of the central incisor. And again, Francesco, you'll agree with me, there's no real way to save this tooth. Now, what I've learned from a dear friend of Francesco and a teacher of mine, Nitzan Bicaccio, is to start surgery with pros. So we did 2 sets of wax-up, one including the 2 central incisors, and another one including the 6 front teeth in order to mask the canines as laterals. We do the mock-up, described by another great friend, Galip Gurel, and we let the patient choose. Now, I know that we are going to do surgery, but this is how we gain trust from our patient, and it's easier for them to understand that surgery is not the whole thing, and prosthetics are as equal, if not more important. So we start, again, you see we're dealing with thin tissue, the same procedure. 15C blade, we remove the tooth. You see, and you will see the defect we have on the distal aspect this time. Antibiotics help prior to surgery. We know this from endo, in order to remove the defect in one piece at time of surgery. And we have 2 craters, one from the defect and another from the alveola. We will utilize, whenever we can, more palatal bone in order to place our implant. You see here that although we have these 2 craters, my implant will be at least 3/4 buccally will have bone, because the anatomy of the region allows us this. In this particular case, the implant will be placed, brought to the proper prosthetic inclination, and then we will graft the case with our membrane, with our bovine material. The thing we will do differently in this case, in order to be even safer, is we will place a collagen plug, suture the area, and bond the provisional to the neighboring teeth, as you see here, from our wax-up. So the reason we do that is that in this high smile line case, with thin tissue, you see here the implant, it's not a matter of primary stability, it's a long implant, is that we even win more soft tissue with this scenario. So it's safer. This is debonded actually, the soft tissue is not completely mature, but if you wait a bit longer, it will be mature. So if we have to enhance further the buccal tissues in a smoker, it's more predictable to perform a roll flap described by Lenny Abrams, most probably before I was born. No, I was a little kid. And have predictable results. This is why I love this technique, because it works with smokers, because we have a great blood supply. In this scenario, we were lucky. We didn't have to graft additionally. We will do a very small, partial punch, like Grunder said yesterday. I prepared for a laminate veneer. You see that we have more tissue than what we need, and we will use that and push that with our prosthetics in order to have a nice gingival display and thick tissues in the area. This is the cast we have, and the reality, you see that palatally we stay supragingival with the biocompatible material because porcelain is also not biocompatible. So we stay with zirconia supragingival palatally. There's no reason to be subgingivally. And this is the final result. So again, without doing anything really complicated, just by understanding the biology in the area, we have a very sound result also from this aspect and our smiling patient. Now, in the last minutes, this is something which is very important. We all know the types and the risk assessment from the Atlanta group, the Atlanta team. One additional assessment I found to be very helpful in my planning is this classification of sagittal root positioning by Joseph Kahn. We know that this is the category, 80%, that we want to deal with when we're dealing with the teeth in the aesthetic region, meaning we have palatally bone. But many times, it's not the case. And in the other three scenarios, we better have bone apically in order to be able to stabilize our implants. So if we do not have a CBCT scan, knowing that we have a first category, that we are in the first category, we cannot really promise anything to our patients. So this is something very, very helpful in our planning to know. Many times, as I've showed you in the previous case, we will have bone buccally to our implant when we are in class 1. So in cases like this, we can have a fractured canine, as you see here. It's mobile. When I move it with my probe, it's fractured. And as you will see, notice where the margins are. We are a little bit more apically. We will proceed with the same procedure. It's always the same steps. 15C blade, mobilize the tissue, remove the restoration, then go further and deeper. You see the fractured root. With the 15C blade, you can even use bendable blades, tunneling instruments to make your life easier. Extract the root. 2 minutes, David, I'm done. As you see here, the defect, no buccal plate. But we know from our CT scan that we have enough bone palatally. So we will move on, place our implant, create a tent with a slow resorbable membrane, overcorrect the area, as you will see in a moment. This is our membrane. The tent, we overcorrect because we do not have now a buccal plate to limit us. Our graft material, we suture. I also utilized PRF in this case, our positioning mattress sutures, a deep bite. You better not load such scenarios immediately. We use a provisional bonded to the neighboring teeth more buccally in order to avoid problems with fractures. This is how it heals. The provisional restoration, bonded to the neighboring teeth. Final abutment, second provisional restoration, and the final restoration. Also from this view, you can see where the margin is, although we did not have a buccal plate in this case. So just by understanding the biology in this area, we can have predictable and beautiful results. My time is up. Thank you very much for your attention. It's really a pleasure to be here.